Dr. Suyesh, we can start in 3, 2, 1. Please go ahead.
Good evening, everyone. I'm Dr. Suyash Sharma. I'm Senior Medical Advisor from Zydus Oncology and Hematology Division. We are honored to be part of today's discussion. And for this honor, we would like to thank Dr. M.B. Agarwal sir and MHG. And so without much further ado, I'll hand over the session to Dr. M.B. Agarwal sir. Dr. Amit sir.
Yeah. Thank you so much. Let me share the screen. Good evening to one and all. Today, our guest speaker for the day is Dr. Renu Saxena from Gurgaon. She is going to lecture us on what's new in pathology of acute myeloid neoplasms. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar and Team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Renu Saxena from Gurgaon, all our discussants who are themselves eminent hematologists, medical oncologists, or hematopathologists, and you participants for sparing your Saturday evening. Do not forget to visit our website, www.mhgindia.com. Tomorrow, that is 11th of December, Sunday, we have a lecture on emerging complications in thalassemia by Dr. Shruti Kakkar from Ludhiana. Now it's a time to introduce all our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditya Jandial from PGI Chandigarh, Dr. Akshay Mandloy from Suraksha Diagnostics, Kolkata, Dr. Ankur Ahuja from RNR Army Hospital, New Delhi, Dr. Arun from PGI Chandigarh, Dr. Chirasri Sanyal from Neel Ratan Sarkar Medical College and Hospital, Kolkata, Dr. Chitra Madiwale from PD Hinduja Hospital, Mumbai, Dr. Debadita Ray from PGI Chandigarh, Dr. Devdutt Basu from Jipar, Pondicherry, Dr. Devdeep De from Tata Medical Center, Kolkata, Dr. Jyoti Bajaj Sone from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Kunal Goyal from Tata Memorial Hospital, Mumbai, Lieutenant Colonel Dr. Kundan Mishra from RNR Army Hospital, New Delhi, Dr. Manjit Mehta from KD Ambani Hospital, Andheri, Mumbai, Dr. Naveen Kakkar from Maharishi Mandakeshwar Medical College and Hospital, Kumarhati, Solan, Himachal Pradesh, Dr. Nikhil Kumar from AIMS, New Delhi, Dr. Parimal Sarda from Hemato-Oncology Clinic, Vedanta, Ahmedabad, Dr. Pradeep Shetty from PGI Chandigarh, Dr. Prochi Madon from Jaslock Hospital, Mumbai, Dr. Pulkit Rastogi from PGI Chandigarh, Dr. Rakhi Kar from Jipmar, Pondicherry, Dr. Rama Hariharan from All India Institute of Medical Sciences, New Delhi, Colonel Dr. S. Venkatesan from Armed Force Medical College, Pune, Dr. Sanjeev Gupta from AIMS, New Delhi, Dr. Sarthak Vadera from PGI Chandigarh, Dr. Senaz Khodaji from PD Hinduja Hospital and Research Center, Mumbai, Dr. Udyan Khachi from Vadodara, Gujarat, Dr. Vidisha Mahajan from PD Hinduja Hospital, Mumbai. Now it's a time to introduce our guest speaker for the day, Dr. Renu Saxena from Gurgaon. Dr. Renu Saxena is MD, FNAMS, Director, Path and Lab Medicine, Head, Hematopathology, Medanta, the Medicity, Gurgaon. She was a professor and head, Department of Hematology at AIMS, New Delhi. Her areas of research include hemostasis, molecular hematology, hemato-oncology, anemia, and quality control. She has over 500 publications in indexed and high impact factor international and national journals. In addition, she has contributed chapters in 75 books and edited almost 13 books. She is a recipient of many prestigious awards and orations, the most important of them being Dr. B.C. Roy Award, the highest honorary for medical fraternity given by the President of India. Shanika Oration Award by Indian Council of Medical Research, which is awarded to a woman scientist for meritorious work carried out in biomedical sciences. Delhi Society of Hematology Oration, Lifetime Achievement Award in Hematology by Mumbai Hematology Group, Dr. Malti Sathe Oration awarded by ISHBT, BGRC Silver Jubilee Oration Award by ICMR, Professor Dinkar Chandra Memorial Oration Award by UP chapter of IAPM, Manorama Sapre Oration 1999 by ISHBT. It's my privilege to invite her to deliver a lecture on what's new in pathology of acute myeloid neoplasms. Well, thank you so much. Over to you, ma'am, for your lecture.
Thank you so much, Dr. Amit, for this. And at the outset, I would like to thank Dr. Agarwal and the organizers for inviting me to give this talk today. And I'm just going to try sharing my screen. Yes. So is it visible?
Yes. Yes, ma'am.
Okay. So this topic is very important today because as in other branches of science and hematology included, a lot of new things are happening in science. So when we talk of what has happened in AML, it is best captured in the various classifications. So whatever new happens at a particular time gets reflected into the classifications. So if we start from near initial, not really initial thing came in 1968, but let's start with something that is akin to similar ones that we have today. So we had this FAB classification in 1976, refined by WHO classification, which came in 1988, where instead of just morphology and cytochemistry, the immunophenotyping was introduced. And this was followed by more parameters being added. And finally, we had, in 2016, we had a revision of the 2008 classification, which was the fourth WHO classification that was there. And this revision happened because so much had then happened about the molecular and the cytogenetics. And from that time till now, another 6 years have gone, and a lot more information is now available. So we actually have a couple of classifications. We have this fifth classification of WHO, which was formulated in 2022. And there's another international consensus classification again in 2022. I'm not going to confuse you with the differences or similarities between the two. Just would want to say that predominant changes remain same or similar with a few things here or there, which we will talk about towards the end of my talk. So, predominantly, I'm going to stick to the WHO classification, since that's something we are all familiar with and we have been following over the years. Now, the basis for this classification is three main legs. We have lineage attribution, which is done by immunophenotyping using either flow cytometry and or immunohistochemistry. We have to take into account the dominant clinical attributes. What this means is we take into account general features of untreated disease, whether it is acute, whether it is chronic, whether there are cytopenias as seen in MDS, or there are cytosis as seen in myeloproliferation, and the biologic attributes, which are basically molecular rearrangements that are there. So I'm going to discuss the changes in these broad headings, which were originally defined in the 2008 classifications. And I'll see what has happened to each of these groups as we have gone ahead with time. So one important thing that has emerged in classifications now is that clonal hematopoiesis has become recognized as a category of precursor myeloid diseases. We had been hearing about clonal hematopoiesis and CHIP and CCUS in several articles earlier, but now it has been all these entities have been formally defined. So let's see what these entities are. So clonal hematopoiesis actually means there is presence of a population of cells which are derived from a mutated multipotent progenitor cell. It has selective growth advantage, but there is no cytopenias, there are no hematological cancer or underlying hematological disorders. And the incidence of this clonal hematopoiesis increases. We still don't know what is the clinical significance of these. All that we know is you need to just follow up these patients to see what happens to them. A step further down this hematopoiesis is clonal hematopoiesis of indeterminate potential. So what is this? This is clonal hematopoiesis with somatic mutations of myeloid malignancy associated genes. which are detected in blood and bone marrow. But what is more important is that the amount of these mutations has been quantified. So you will recall in NGS, you get this variant allele fraction, right? So a variant allele fraction more than 2% is considered to be significant and is considered to be part of this chip. Of course, it stands to reason that there is absence of any underlying hematological disorder or unexplained cytopenia. And why have they taken this 2%? Because the significance of variants detected in lower levels is at present time unclear. So the next in this group is clonal cytopenia of undetermined significance, or CCUS, and this is an edge above CHIP. So CHIP with presence of one or more persistent cytopenias, which again do not have underlying hematological or non-hematological conditions, and do not meet diagnostic criteria of any defined myeloid neoplasm, is CCUS. What has also happened is that the cytopenia definitions have been harmonized for CCUS, MDS, and MDS-MPN. So what are these definitions? Hemoglobin less than 13 grams per deciliter in males and less than 12 grams per deciliter in females. Absolute neutrophil count less than 1.8 into 10 to the power 9 plus liter. And platelet count less than 1.5 lakhs for thrombocytopenia. So a lot of times we get, with the NGS becoming so common, we do order NGS for quite a few patients and you get some mutations. How do you interpret those mutations? So if you have mutations in cytopenic patients without extensive dysplasia or excess blast or a typical MDS defining karyotype, how do you decide, is it a CHIP or is it more towards a MDS? So there are some pointers. If there is a single mutation or the variant allele frequency is less than 10%, there is minimal or no cytopenia, and the mutations in CHIP are usually like TET2, DNMT3A, etc. Then this combination favors a CHIP, or any one of these also favors a CHIP, unless you have one of these. So what are this criteria? Multiple mutations, if they are present, having a higher variant allele frequency more than 20%, and cytopenias, especially if over a period of time they are progressive. And the mutations which are more commonly associated with MDS, like TP53, U2F1, these combinations favor MDS. So depending on the kind of mutation you get and looking at all these features, you can have an idea, is it more like a CHIP or is it actually going into an MDS category? So therefore, we then go on to the next very close entity, that is the myelodysplastic syndrome. What are the changes that have been in this? So one important thing has been in the nomenclature, which is in keeping with the myeloproliferative neoplasms. So the myelodysplastic syndrome has now been called myelodysplastic neoplasms. So to summarize the main changes, it is renamed as myelodysplastic neoplasm, and there are MDS, two types are there. The genetic type has been updated to include some variants. I will just go into this a little shortly. Hypoplastic MDS is recognized as a distinct disease entity, and MDS has been divided into MDS with low blast and MDS with increased blast. And then terminology of childhood MDS types has been updated. So let's look at the classification of MDS as it looks now. So in the category of MDS with defining genetic abnormalities, we have MDS with low blast and isolated 5q minus syndrome. So in this, we have blasts which are less than 5% in bone marrow, 5q deletion alone, or with one more abnormality other than monosomy 7 or 7q deletion is suggestive of this category. Then we have MDS with low blast and SF3B1 mutation. So we know for quite some time SF3B1 has come into a vogue and it is now very important for this particular category. So we have to see there is absence of 5q deletion, monosomy 7 or complex karyotype. It's important to note in this, if you look at ring sideroblasts, they will be more than 5%. But you may have cases where ring sideroblasts may be more than 15%, but SF3B mutation is not present. And in such cases, the terminology to be carried out is MDS with low blasts and ring sideroblasts. A new category which has also been added is MDS with biallelic TP53 inactivation. And this is usually complex, and we will go into its depth a little later. Then in the MDS morphologically defined type, the terminology has been changed. MDS with low blast has less than 5% blast in bone marrow and less than 2% in peripheral blood. MDS hypoplastic has been added as a distinct category. MDS with increased blast has been divided into two. MDS IB1, which is like 5 to 9% blasts in the bone marrow, and MDS IB2, which is 10 to 19% in the bone marrow. And you may have R-rods. If R-rods are present, it goes into MDS IB2. MDS with fibrosis, having 5 to 19% of blast in bone marrow, is also included in this. It's important to know that when we talk of hypoplastic MDS, cellularity has to be less than 25% as per the age. So therefore, if we look at some of the changes which are there in addition to what I've said, apart from having these two groups, the distinction between single lineage and multi-lineage dysplasias is now considered optional, and almost nobody talks about the differentiation anymore. MDS unclassifiable has been removed. The blast cutoffs have been eliminated for most AML types, but with some they are still there. So the 20% blast cutoff to delineate MDS from AML is still retained, because I think just for want of a number, but I'm sure in due course of time, this distinction is going to go away. But currently it is still retained. MDS IB2 may be regarded as an AML equivalent for therapeutic considerations, and these people may be treated as an AML. Coming to MDS with biallelic TP53 inactivation, which is a new entity which has been added. So here you get sequence variations, copy neutral loss of heterozygosity. So 2/3 of such patients have multiple TP53 hits, and these are consistent with biallelic TP53 alterations. So its detection is done predominantly by sequencing. We do it by NGS, but you can also use FISH techniques having specific probes for the various copy number studies. More than 90% of patients with MDS biallelic TP53 have complex karyotypes, and they have a poor prognosis as well. Hypoplastic MDS, which is again a separate entity which has been added, is a distinct MDS type now. And basically the T-cell mediated immune attack on hematopoietic stem cells, along with the expansion of CD8 positive cytotoxic cells, is present. Many features overlap with the aplastic anemia and PNH because it's all actually stem cell disorders, and they may even get some responses with the aplastic anemia drugs. Childhood MDS has been a little more clearly defined. So we have now two major entities: childhood MDS with low blast and childhood MDS with increased blast. The childhood MDS with low blast has less than 5% blast in bone marrow. This has two subtypes. It could be hypocellular or it could be not otherwise specified. Childhood MDS with increased blast has 5 to 9% of blast, and therefore it can be categorized as per that. So if we talk of childhood MDS with low blasts, we have two varieties, as I said, hypocellular and NOS. So it is important that exclusion of non-neoplastic causes of cytopenia, such as infections, vitamin deficiencies, metabolic diseases, bone marrow failures, syndromes, all these have to be excluded before putting into childhood MDS with low blasts. And about 80% of the cases, however, show hypocellular bone marrow. Juvenile myelomonocytic leukemia, myeloid proliferations associated with Down syndrome, post-cytotoxic therapy, etc. All these have been excluded from this group and now belong elsewhere in the group, and I will touch upon them as we get into those groups. Then we move on to the next group, that is the MDS-MPN group. So what are the major changes? So the CMML diagnostic criteria has undergone revision, and we will talk about this. Atypical CML has been renamed as MDS-MPN with neutrophilia, MDS-MPN with ring sideroblast and thrombocytosis has been redefined based on the mutation and is being renamed. So let's see. So currently, these are the categories in MDS-MPN group. And as you can see, MDS-MPN with neutrophilia has come as a distinct group. So major changes in CMML diagnostic criteria. So in the prerequisite criteria, persistent absolute monocytosis more than 0.5 into 10 to the power 9 per liter, and also relative peripheral monocytosis has been included, more than 10%. The rest remain the same as it was. In the supporting criteria, in addition to dysplasia involving more than one myeloid lineage and acquired clonal cytogenetic and molecular abnormalities, there is another one that is added, that is the abnormal partition of peripheral blood monocyte subsets. Now, what does this mean actually? So what these are based on increased classical monocytes in the absence of any known active autoimmune disease or systemic inflammatory syndromes. Now, this is a very important point. So he recently had a patient who had increased monocyte count, but also had lung infection and had actually SARS, systemic inflammation. So in such a case, would you call it a CMML? And he was a 70-year-old male. So this is a very important criteria. So if you have absence of any active autoimmune disease or systemic inflammatory syndrome, then only you will consider a CMML on monocytes, high increased monocytes. So what are the requirements for diagnosis? The prerequisite criteria must be present in all cases. If monocytosis is more than 1 into 10 to the power 9 per liter, which is what was the earlier criteria, then one or more supporting criteria must be met. But if monocytosis is more than 0.5, then you need to have criteria 1 and 2, which have to be met. Supporting criteria have to be met. So in addition to this, some other changes that have happened is, the WBC count has been defined to differentiate between the myelodysplastic CMML and myeloproliferative CMML, and a WBC cutoff is 13 into 10 to the power 9 per liter. So CMML 0 has been eliminated. So this is what used to be less than 2% blast in blood and bone marrow, because it has very limited prognostic significance. So today we have two CMML subtypes, CMML1, which has less than 5% blast in the peripheral blood, less than 10% in bone marrow, and CMML2, which has 5 to 19% in peripheral blood and 10 to 19% in the bone marrow. Coming to the other subgroups of MDS-MPN, as I said, atypical CML has been renamed as MDS-MPN with neutrophilia. MDS-MPN with ring sideroblast and thrombocytosis has been renamed based on SF3B1 mutation and has now been called MDS-MPN with SF3B mutation and thrombocytosis. MDS-MPN ring sideroblast thrombocytosis is retained for all those cases which have wild type of SF3B1 mutation. And of course, MDS-MPN unclassified term has been now called as not otherwise specified. We move on to the next group, that is the myeloproliferative neoplasms. So salient changes include CML phases have been consolidated into chronic phase and blast phase, with more emphasis on risk features in chronic phase. The diagnostic criteria of chronic eosinophilic leukemia have been updated, and the qualifier NOS has been omitted. JMML has been characterized under myeloproliferative neoplasms. So now myeloproliferative neoplasms include, in addition to all the previous ones, the JMML also. So let's see what has happened in CML. The accelerated phase, which we used to do all the blast counts and everything, is no longer required. And this is because in the tyrosine kinase inhibitor era, The incidence of progression to advanced phase disease has decreased, and 10-year overall survival rate remains 80 to 90%. And therefore, the designation of accelerated phase has become less relevant, and more important for risk has now been advocated that it is resistance from the ABL1 kinase mutation or additional cytogenetic abnormalities and the development of blast phase. So this is one major change that has happened. In the other BCR ABL negative MPNs, not too much change has occurred. In polycythemia vera, determination of increased red cell mass with 51 chromium labeled red cells actually went away in actual real world quite some time back, but now it has been officially removed as a criteria of PV. In PMF, ET, and chronic neutrophilic leukemia, not much changes have happened. Some changes have happened in chronic eosinophilic leukemia. An important change is that the time required to define sustained hypereosinophilia is reduced from 6 months to 3 months. Addition of requirement for both clonality and abnormal monocytes is there. Therefore, there has been elimination of increased blast as a alternate, because this has been replaced with clonality, abnormal clonality and abnormal bone marrow morphology. The qualifier not otherwise specified has been omitted. Coming to JMML, this is now included in MPN, and basically there is no KMT2A rearrangement in these. There is elimination of monosomy 7 as a cytogenetic criteria, which used to be there earlier. In fact, more emphasis is now on diagnostic molecular studies, which is demonstrating the RAS pathway activation. So coming to acute myeloid leukemia. So this has been divided into two groups, as it was earlier: acute myeloid leukemia with defining genetic abnormalities, and the other is AML defined by differentiation. So in the group of defining genetic abnormalities, there have been some changes. There has been inclusion of new entities like AML with KMT2A rearrangements, AML with MECOM rearrangements, AML with NUC98 rearrangements. AML with BCR-ABL fusion and AML with NPM mutation, which was earlier in a provisional category, has now been included in this. And a new category of AML with other defined genetic abnormalities, a broad group, which is actually keeping it open for any further genetic abnormalities which get discovered, which can be added into this. So therefore, what further changes are there? AML with BCR-ABL1 and AML with SEPA mutations are the only subgroups in the AML with defined genetic abnormality that require at least 20% of blasts. In the others, you really don't need 20% of blasts. So there has also been a change in the SEPA mutations. Earlier, it was only having biallelic SEPA, but now in addition to this, single mutations located in basic leucine zipper phase of the gene has been included, and these generally have a favorable prognosis. AML with RUNX1, which had been added as a provisional entity in the previous classification, has now been removed because these mutations actually lack specificity as a specific AML subtype. Coming to AML MR, what is this? This is a term which replaces AML with myelodysplasia-related changes. And in this, of course, more than 20% blasts have myeloid immunophenotype. There are specific cytogenetic and molecular abnormalities, and this can arise either de novo or following MDS or MDS-MPN. What has happened is morphology alone is now totally removed. Cytogenetic criteria have been updated and mutations have been added. Specific mutations based on the set of these 8 genes have been found that these are present in more than 95% of the of these AML MRs. So these are the cytogenetic abnormalities which are now included, and these are the 8 somatic mutations, and we get them in the NGS so often, which are very, very characteristic of AML MR. Acute erythroid leukemia, not much change has occurred. The diagnostic criteria remains as it was, but it has definitely been shown that they have a high prevalence of biallelic TP53 alterations, which confer a poor prognosis. In acute megakardioblastic leukemia, there are three clinical groups: children with Down syndrome, children without Down syndrome, and adults. Basically, you still need to have the immunophenotype markers of megakaryocytic morphology to make a diagnosis of this. What is important is that this is a newly described immunophenotype, RAM immunophenotype, where there is a very strong positive CD56, week 34, and week 117. And this is associated with poor prognosis and has been found to be present in acute erythroid leukemia. Sorry, acute megakaryocytic leukemia. Coming to secondary myeloid neoplasms. Now, we have three groups here. So we have myeloid neoplasms, which are secondary to exposure to cytotoxic therapy, or they may be due to germline predisposition. AML transformation of MPN is retained in the MPN category, and AML transformation of MDS is retained in AML-MR. So actually, we have only cytotoxic therapy and germ dispositions. So this has a term myeloid neoplasms with post-cytotoxic therapy is now replacing therapy-related AML-MDS. And it has been found that exposure to PARP1 inhibitors also can lead to this. And this is actually added as a qualifying criteria for this MNPCT. Methotrexate has been excluded, and specification of the type of myeloid neoplasm, therefore, we put as AML or MDS PCT. So if it is an MDS, we say MDS PCT. If it is AML, we say AML PCT. Coming to germline myeloid neoplasms associated with germline predispositions. So broad groups were present as earlier. What I've highlighted in these red empty circles are the new ones that have been added. So these are important to know, because in these conditions, you need to take a good family history. And when you do NGS, you get these kind of changes. It points towards a germline predisposition. We had one case where we actually found ETV6, and it was actually also a patient having a platelet function disorder. And having a look at this, we could actually put it as germline predisposition and ask for a very close follow-up in that patient. Chronic eosinophilic leukemia. Salient features. So this family has been renamed as myeloid lymphoid neoplasms with eosinophilia with tyrosine kinase gene fusions. Recognition of novel subtypes have been there, and a new scalable genetic framework has been introduced. So let's see what this looks like now. So we have PDGFR alpha rearrangement may be there, PDGFR beta would be there, FGFR alpha, all these were there even in the previous classification. What is new is the JAK2 rearrangement, FLT3 rearrangements, ETV6 ABL fusions, and other defined TK inhibitors, which have a whole host of these which have been added. And these are open. As more and more partners of ETVCX come up, they will be included into this. So it has actually undergone the maximum changes in these group of subgroup. Now, coming to acute leukemia of ambiguous lineage. So main changes. So basically, we have these acute leukemia of ambiguous lineage with defining genetic abnormalities, as was there previously, and those which are immunophenotypically defined. What has happened is that new genetic findings are now listed as subtypes under this subgroup. And lineage assessment criteria for MPL has been mildly redefined. So we have these categories which were there. Important is MPAL with ZNF subgroup which has been added. And of course, we have immunophenotypically defined subgroups. And what has happened to them is in the lineage assignment criteria, though the criteria remain similar to what it was earlier, they have defined what is strong and what is weak. So strong is CD19 intensity, which is exceeding 50% of the normal B cell progenitor by flow cytometry. Weak is when it is less than 50% of the normal B cell progenitor. Similarly, for T cell lineage, CD3, either cytoplasmic or surface, can be considered. Coming to the last group, that is the mastocytosis. So salient changes include diagnostic criteria for mastocytosis, which have been refined. What has happened is CD30 has been added, and a few other mutations have been introduced as minor diagnostic criteria, which I will just come to. Bone marrow mastocytosis has been defined as a new systemic mastocytosis subtype, and KIT D816V mutation with a variant allele frequency more than 10% now qualifies as a B finding. So what it means, when you look at the mastocytosis types and subtypes, the bone marrow mastocytosis comes as an individual entity which has been added to the various groups of systemic mastocytosis. And then we look at the changes in the B and C findings. So in the B findings, the high mastocyte burden, we have included now KIT D816V with a variant allele frequency more than 10% in bone marrow and peripheral blood leukocytes, and signs of myeloproliferation or MDS remain. Organomegaly would be there, palpable hepatomegaly without ascites, or the signs would be there. In the C findings, not much change has occurred and it remains as it used to be. So therefore, what are the criteria to diagnose systemic mastocytosis now? You have the major criteria, which remain as they were, that is multifocal dense infiltrates of mast cells in bone marrow. Minor criteria remain the same. The only thing is that KIT activating point mutations at codon 816 and other critical regions have been added. Muscles in bone marrow blood expressing CD25 as before, but CD30 has also been added now. And of course, the baseline serum tryptase concentrations have been added. In the case of a known hypertryptasemia, tryptase level should be adjusted. So if at least one major and one minor, or three minor criteria are fulfilled, the diagnosis is that of systemic mastocytosis. So with this, I would like to summarize that the 5th WHO classification of myeloid neoplasms is a great advance over the previous ones and reflects newer changes in the pathology of myeloid neoplasms. It also leaves some entities open to further advances, means these are broad groups where future things as they are discovered, they can be added. And I would like to bring to your notice that simultaneously with this classification, the International Consensus Classification 2022 also became known and published. And this also highlights the changes in myeloid neoplasms. There are several similarities and a few differences, but for the current purpose, I think we need to wait till there is an attempt going on to harmonize these two classifications so that one common classification emerges that is going to allay the confusions that have arisen because of these two classifications. But as far as we are concerned, as lab people and as people who are treating AML or myeloid neoplasms, we should try to upgrade our labs and translate all these changes if we can to our day-to-day practice. So with this, I would like to thank you for a very patient hearing.
Thank you so much, ma'am, for that wonderful and excellent lecture. You were so fabulous, covering top to bottom everything in the myeloproliferative neoplasm, what's new in 2022. Thank you so much for that, ma'am, once again for that lecture.
Thank you.
We have some Indian colleagues now who are going to bother you with the questions.
Yes.
And for that, we have many delegates in the audience as well as in the chat box. We'll start first of all with audience here. So if you've got any question, please have a raise hand signs. So we'll go one by one with your questions.
Sanjeev has a question.
Thank you so much, ma'am, for this excellent overview of the topic and the latest changes. Are we going towards a mandatory NGS requirement in all cases?
It looks like that. It looks like, at least for myeloid neoplasms, I think we are going towards NGS. Actually, at our setup, we are actually doing for our myeloid, whether it is MDS or chronic myeloproliferative, not really chronic myeloproliferative yet, but MDS and AML, we are routinely doing NGS. And we're doing it in our in-house. So, like, I think it's become part of routine already. And in fact, when we look at NGS mutations, we used to see all these mutations which have now come in this classification. We used to wonder what to do with them. So this has become a kind of Bible for us, so to say, gives more clarity.
Yes.
So, yeah.
Another thing you highlighted about was the blast percentage criteria, like that has been reducing from 30 to 20 and now to 10. And maybe that will go away once we have more genetic information available.
So, one of the reasons why they talked about this fluid thing about blast percentage is because every time you count in different areas, you come up with different counts. And that is why we are moving towards very soft differences between the two.
Yes.
So let's see how it progresses.
Thank you so much.
In fact, in the newer classification, this cutoff percentage has been reduced to 10% in that other classification.
ICC.
So we let these people discuss, the ICC one. Let them discuss and let us see what consensus actually emerges out of large studies. That's what it is.
So just in case, ma'am, if there is any discrepancy, like suppose there are 8% blast with defining abnormality, like according to the WHO, it is an AML. But according to ICC, we need 10% blast.
That's exactly what I'm saying. They need to sit together and harmonize what it is. This is only creating confusion. I agree with you.
Should one make a note in the report, or we should not create that?
I think they are already discussing. Actually, I had access to some of the PPTs where they're looking at the alignment of the two classifications. And a lot of discussion is happening even now in the pathology conference, CAPS conference, which is going to happen. And I think even in ASH, there is this two classifications. There is a session on this. So I think they are already working towards it. And certainly if you want, we can add, but I think there are already huge discussions going on in this.
Okay. Thank you so much, ma'am.
Thank you, sir. Dr. Vidisha Mahajan, your question, please.
Good evening, ma'am. Thank you so much for the wonderful talk. Got a lot of insights into the newer classification. One question was that, is there any role for screening for clonal hematopoiesis at the present moment? Like, is there any population where we say that we should be screening?
So, what will you do if you just screen a population? You will ask them to follow up. And follow up for what? Follow up for development of cytopenias. So in the real world, you actually investigate when a patient presents to you with some cytopenias. But why is it important to know that such a thing exists? Because sometimes we do come across patients who've got a NGS done somewhere for whatever else, but they found one kind of abnormality over there. They come to us, are we having MDS or not? They have no cytopenias, no symptoms, just a particular mutation which may be there. So therefore, it is important. If you get such a patient referred to you, you can at least guide them that as of now, right now, nothing, but keep a close follow-up. So I don't think we really need to look into the population for this. I recently came across an article that at birth you have tele-AML, but the patient has nothing. So, if you just keep on looking, you may just find something. Okay. So I think we have to go a patient-oriented approach, and only if the patient comes to you with some symptom or some finding, one should investigate.
And my second question was related to the defining of the percentages for the intensity for these mixed phenotype, ma'am, like 50%.
Yes.
That will become a little,
So, it's not 50% of cells. It's 50% of what it happens in normal B lymphocytes, for example.
Okay.
So normal CD19. So you have your intensity of in your own flow, normal B lymphocytes or CD19 intensity is X. So if here it becomes more than that X, then you will put it as CD19 positive for MPAL. But if it stays less than that, it becomes weak positive. So it becomes strong. So you have to compare it to your population of normal CD9s. Yeah.
And then we'll have to report these percentages as well then.
Actually, that is in the criteria that if it is more than 50%, it is strong. But as part of your report, you should put.
Okay, ma'am. Okay.
But for classification, you can say it is strong. When you give your final report, you say it is strong or is it weak, and thereby put your criteria for the MPAL.
No, thank you so much, ma'am.
Thank you, ma'am. Dr. Nikhil, your question, please.
Yes.
Thank you, ma'am, for the excellent talk. You covered everything so comprehensively and very well.
Thank you.
Ma'am, my doubt is, ma'am, in AML patients at baseline, either cytogenetics or NGS, very often we come across a host of mutations or cytogenetic abnormalities. So would you recommend following up these patients post-therapy to see whether these mutations persist?
Always. Always you have to do that. You must follow up these patients always. And you anyway do mutation analysis on follow-up, because you can also look at molecular MRD. See, we do flow MRD for AML, but we also look at these mutations also.
Yes, ma'am. That was my second doubt, ma'am. Which among these abnormalities would you prefer for a molecular MRD assessment?
Very difficult question, but a lot of work is now going on but people do. So the genetic abnormalities which are there, which are defining, you certainly would want to look at those.
Definitely.
The significance of other molecular abnormalities which are not defining is very difficult to say at this point of time till we have more studies.
Okay, ma'am. Because very often in NGS, we get a host of mutations.
NGS, exactly. NGS really confuses you quite a bit. So I think it is a little premature to say how many of the mutations that you get in NGS, which are not genetic defining, actually need to be done as of now. But let's see how it goes.
Thank you, ma'am.
Thank you, Dr. Nikhil. Ma'am, I have one question actually.
Yes.
Now, ELN 2022 guidelines for AML is coming up with new things actually. And in that it's written that FLT3 mutation is positive. And suppose patient has got FLT3 mutation positive and also core binding factor also positive. So what group it will belong to? Whether favorable, unfavorable, intermediate risk? Because it's totally confusing.
This is a very difficult question to answer because we get this so often.
Yeah.
So I think generally finding which is not favorable supervenes. That's what I've generally seen. A finding which is not favorable supervenes on the good prognostic finding. The only exception I think is NPM. But predominantly it is the bad prognostic finding which supervenes on the others. But I read a statement somewhere that if you have NPM with a bad prognostic thing, NPM reduces that bad prognosis of that, which is there. So NPM does confer a good connotation. But whatever it is, it will not be as good as NPM alone. So when there are two things that are happening, one is favorable or intermediate and the other is poor. The poor one is going to supervene. That's what we have found.
Because if we are getting two things like this, FLT3.
Yes, we also get them, and it's very confusing. I agree. So we invariably just leave it at that because we don't give prognosis, because we have to see how that patient behaves, because literature doesn't talk about this.
True.
So, yeah.
Dr. Akshay, your question, please.
Yes.
Thank you, ma'am, for the wonderful webinar. Ma'am, actually, my question is regarding MPO positivity. It has been often observed that flow cytometry, we are getting MPO negative, but the same blast are more than 3% blasts are positive in cytochemical MPO, for cytochemical MPO.
Yes.
And it becomes important when the blasts are already flow cytometrically expressing some other lineage, for example, B lineage. So in these cases, should we label it B lineage, BALL with aberrancy of myeloid markers, or on the basis of positive cytochemical MPO, we should label it as MPAL, B myeloid?
You know, MPO, it can happen. That we have also seen that cytochemical MPO can be very nicely positive and your marker does not come in, it happens. So it is either that or this positive. You take it as positive.
Should we in the report give both the differential that it could be BLL with aberrancy of myeloid markers, or it could also
it's only going to confuse more. I think you take MPO positivity as a positivity. That's what I think.
Okay.
That's what we used to do at AIMS. We used to take either this or that. Yeah. Currently, we don't do MPO cytochemistry, but I personally believe we should always do MPO cytochemistry because of this reason, what you have highlighted. Yeah.
Thank you, ma'am.
Thank you, Dr. Akshaya. One question we have in the chat box, ma'am. Dr.
Yes.
Singh wants to know that have you ever come across a case of de novo blast crisis?
Which one?
De novo blast crisis, lymphoblastic crisis, in a case of CML in a patient 10 years of age who is P210 kilodalton positive, BCR-ABL positive.
P210.
P210, yes, 210. And few weeks history of illness, basophils are seen in the peripheral smear, and bone marrow has got 90% blast, and these are all lymphoblast.
This can happen. We have seen several cases of blast crisis in CML who present for the first time as acute leukemia. And generally it happens in P210 subtype of the CMLs. And the blast crisis has varied from lymphoblastic crisis to even myeloid blast crisis. In fact, there was one patient who we got who was labeled as acute leukemia, was treated as such for ALL, because at that point of time, I don't know, somehow it was not thought of. And when the patient went into remission, he actually went into CML-CP phase. This was at a time when BCR-ABL was not so commonly available, long time back I'm talking about. So this can happen.
Thank you, ma'am. Dr. Shehnaz, ma'am, your question, please.
Firstly, wonderful talk, Renu. You decoded this new classification really well. I think it's a bit confusing. And as someone already rightly pointed out, I think we can't go forward without doing the NGS, because even in MDS, they say that, you know, even if there is no signs or symptoms, then you, if you find an abnormality, a genetic abnormality, then you call it, you know, MDS. So for that, you have to do some kind of molecular genetic workup. So my question is, you know, with the diagnosis of erythroleukemia, so I find it a bit ambiguous in the sense that they say more than 80% cellularity and more than 80% blasts and more than 80% pro-erythroblasts. Yeah, but they do not, there is no need to find blasts in this. So therefore only the TP53 mutation is going. Many times you do get an erythroid hypoplasia and, you know, patients with say B12 deficiencies or in patients with hemolytic anemia where you get more than 80% just, you know, just erythroid cells, and proerythroblasts will obviously be more because of the turnover of the marrow is quicker. So, so the diagnosis is how, I mean, this is diagnosis dependent.
I think there are a few other things also that you have to look at apart from just the blast. I know that is what is written, but if you read the finer print, you also get a lot of dyserythropoiesis. You get a lot of gigantic.
Not mentioned. That is why I'm saying that.
I know, but we know that it is very much a part of it.
There should be dyserythropoiesis, is what even I was.
Yes, absolutely.
Regarding this question regarding acute erythroleukemia, is there any specific marker where you can say that this is acute erythroleukemia?
Glycophorin is something that used to be done. PAS used to be done to pick up these abnormal or dyspoetic erythroblast. You would get it. And we, of course, do CD79, but that's not going to pick up only the erythroblast. Right? It will pick up all erythroblasts, normal as well as abnormal. So PAS and glycophorin, I think, can help.
Ma'am, in that acute erythroleukemia, the IHC will helpful, because in IHC you will do E-cadherin and TP53 mutation and all. So that will.
Yes, that may help, but E-cadherin can sometimes you can get even in normal erythroids.
Dr. Parimal, you are muted. Dr. Parimal, we can't hear you. You are muted. Please unmute yourself.
I already told.
Yeah.
Yeah.
Okay.
Okay.
Fine. So we have next question from Dr. Pulkit Rastogi. Dr. Pulkit, your question, please.
Yes.
Yeah. Yeah, so hi, ma'am, very nicely comprehended all the AML and other myeloid entities. So my question, maybe it's a comment or open house comment for all the experts sitting here, how we are going to move from 16 to 22, because currently while during reporting, sometimes I recently faced 2 cases of accelerated CML, but the WHO 22 says it's no longer. But in our setting, in the Indian setting, we have to fix somewhere. I think how should we solve those problems? Should we write according to WHO 2016 classification or WHO 22 if we have applied an NGS thing? How should we move ahead?
So I think you have to have discussion with your counter clinicians, actually, what they expect from you. A lot depends. See, as a pathologist, you have to cater to what your clinicians want, isn't it? So you
Yes.
have, I think, to check with them. Are they in alignment with the newer classification? Are they okay if you just do this? And of course, you would have to move on to doing TKI resistance mutations. Those, of course, are some things that you have to gradually bring into the routine practice. I think a lot of people have already got it into practice. So mutations. Otherwise, whether the blast count is, let's say, 11 or 12, and if it's not going to alter because you are anyway going to give TKI, if resistance is not there, that patient is likely to respond anyway.
Yes.
So I think you have to consult your clinicians and you have to move on, I think, to these resistance mutations eventually.
Thank you.
Thank you, Dr. Pulkit. Dr. Debadita Ray, your question, please.
Good evening, ma'am. Thanks for this excellent talk, and it's a great talk. So my question was, according to the ICC classifications, they have mentioned that the MDS with TP53 mutations, we need the biallelic or the multi-hit TP53 mutation. But in the MDS AML or in the AML with TP53 mutation, we need the single hit mutations. So how this TP53 mutations biology is different in these 3 entities, and why they are talking this in case of MDS, we need multi-hit. In case of MDS AML, we need the single mutations, and AML also single mutations. And for all these cases, we have to go ahead with the TP53 sequencing as well as microarray also, because loss of heterozygosity is also a criteria in case of MDS with TP53.
Oh, yes, you can do microarray, or you can even use fish probes which pick up loss of heterozygosity. We actually do some fish probes, fish analysis for loss of heterozygosity. But what ICC talks about is something different. And frankly, I have no idea why they have put it like that. I think we have to just wait till they come out with some kind of a consensus. I mean, I really don't know about that part.
Thank you.
Thank you, Dr. Debadita. Dr. Chitra Madivali, your question, please.
Thank you, Professor Saxena. It was wonderful.
Thank you.
It was a very complex topic for me.
It is.
I am basically a histopathologist, so more interested in changes that we see in the tissue sections. I was just curious to know, could you tell us a few salient aspects about ALK positive histiocytosis?
ALK positive histiocytosis.
Yes.
So basically, you want to see what IHC we should do?
Yeah, IHC, and I mean, what are the implications? I've never seen such a case, but I would want to know how to recognize it.
Frankly, I've also not seen, but CD30 is something that we always put up in such cases. And CD68, of course, we always put up in such cases, because you have to differentiate it from closed differentials also, isn't it?
Right.
But I haven't seen, so I can't say too much about that. Yeah.
Thank you.
Thank you, ma'am. Dr. Manjit Mehta, your question, please.
Madam, thank you for an excellent talk and for simplifying it for us, for all the various different subtypes and the newer classification. It was just amazing. So as a geneticist and a diagnostic and a laboratory person offering you all these diagnostic tests, my thoughts are in the present scenario where PCR is available for all the mutations, all the translocations, and PCR being much more sensitive and the capability of multiplexing, what do you foresee as a future for fish?
A fish? No, I think fish still has some advantages over it. And we have seen, so fish, loss of heterozygosity is something you can pick up more on fish. You have those probes and you pick up. And then, there are some of these cryptic mutations that are there that you pick up on those specific fish probes. So I think fish will always remain one of the additional modalities for hematological malignancies, actually malignancies in general, I think. Fish gives an added advantage. We have seen some cases which come out negative with RT-PCR, but come out positive for fish. Even some things like CML, where we very strongly suspect BCR-ABL has to be positive. And we know in literature, PCR picks up 10 to the power minus 6 and fish only picks up 10 to the power minus 3. That's all literature. I mean, I believe in that. But then we've seen cases where this happens. So I think it is a good supplementary test, always.
Yeah. It could be some such reason that, PCR inhibitors are definitely present in a lot of these samples. Yes. And PCR, because of its strong property of amplification, that is the reason why it leads to this, due to this inhibition, it's not able to amplify. Yes. That could be the reason. So you see fish staying for a long time. Yes, we see fish.
We do both. Well as I see fish continuing to come. In fact, for Philadelphia, like ALLs, we get it on fish only.
So I completely agree with ma'am. I would like to add one more point. Just like ma'am said, in PH like ALL, like we can have break apart probes like ABL1, ABL2.
We have that only.
Because of multiple partners, we can use break apart in fish. Yes. And in fact, in PCR, one of the cases, ABL was partnering with SNAX2 gene, which was covered in PCR, but it was coming negative. So there we found out that the breakpoint was different. That is why, because the primers that we were using, they were not working because the breakpoint was different. So fish is quite useful in addition to PCR in many cases.
And especially cryptic cases, it really picks up.
So I think, and madam, one last point on cytogenetics. It is and it will remain the gold standard.
Yes, it will
required for every case.
Not gold standard. We may not say gold standard, but cytogenetics will remain because so many times we get complex cytogenetic abnormalities which are not picked up on fish also. No, there are some numeric abnormalities which, of course, you can use probes which are numeric, trisomies, etc., can be picked up by fish. But cytogenetics will remain because there are many features many things you get from cytogenetics which you don't get in fish also. So I think it will also remain one of the supplement tests.
Yeah. So, I mean, we need to be able to offer the entire spectrum to the clinicians.
Yes. Cytogenetics, fish, molecular. I mean, today we have to have all these three. And NGS, of course, now is added. So we are now actually going on to whole exome sequencing and clinical exome sequencing. But it is too premature for me to say how much of its use is there in hematology, malignancies. We are currently doing it for some prediction models for coronary artery disease. Yeah.
Yeah. Interesting. Thank you.
Thank you, ma'am. Dr. Jyoti Soni, your question, please.
Yeah.
You're muted, ma'am.
Jyoti, you're muted.
Good evening, ma'am.
Hi.
Thank you, ma'am, for this nice talk, ma'am. Ma'am, my doubt was that we can see myelodysplasia in AMLs also, and then we have myelodysplasia when they are considering MDS refractory cytopenias, but sometimes the history is not very clearly available. Now with this 10 to 20% blast count that has come up now, you can consider MDS with 10% and AML also with 10%. How do we give a report? Because sometimes clinicians ask us, should we treat the case as MDS or should we consider AML? Especially when history is not very clear, ma'am. And we are getting myelodysplasia in the marrow.
So now two things have happened. Morphological myelodysplasia is out of the window. Nobody talks about it. So if you have a patient who may have any amount of morphological myelodysplasia, blast count between 10 and 20, and you don't know what it is. But you have that genetic AML with genetic abnormalities where apart from BCR, ABL1 and SEPA, you don't need a 20% count. So if you have any of those abnormalities, it goes clearly as AML. But if it's any of the other abnormalities, then you will, and then the mutations of MDS, that group of 8 mutations which I showed, if it has any of those mutations, so NGS, you have to go for NGS if your recurrent genetic markers are negative. That's why I'm saying for MDS and AMLs, we are moving towards NGS now.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. One question has come in the chat box. Dr. Meeda Radhakrishnan has a question.
Yes.
Are there any subsets based on morphology or flow where you would ask for further workup for germline predisposition?
So, on NGS there are. I mean, if you get ETV6, okay, that is a big predisposition to germline. So a lot of the germline mutations, which I enumerated, majority of them you will get on NGS. Almost all of them you get in NGS. But some of those which you can get on PCR, if you have that PCR standardized, and if those mutations are there, for example, RUNX1 was previously there, it is still there. If you get RUNX1, you must look at platelet abnormalities, and you must at least ask for family history. So family history, other disorders associated with it, you should definitely look at. I've only come across one case that we had, who was a child who had ETVCX, and we kept discussing amongst us, this we have to be very careful, this patient may be having a germline predisposition, we have to take family history. So we got the family testing done also for NGS. We didn't find it, that's a different thing. But at least you should investigate. That's what I think.
Absolutely. One more question I have. Sometimes it becomes very difficult on the bone marrow biopsy between severe aplastic anemia and hypoplastic MDS. Sometimes it's overlap. So we do find dysplasia in both aplastic anemia also as well as hypoplastic MDS also.
Totally.
And some cytogenetics are overlapping in both. We may get in aplastic also as well as in hypoplastic MDS.
Totally.
In this condition, how do you differentiate between hypoplastic
Very
MDS?
difficult. You have to resort to molecular studies and NGS. You have to resort to that. And cytogenetics also. So we can't do away with cytogenetics and molecular genetics.
Thank you so much. And no other questions in the chat box. If anybody has any question for ma'am, is free to ask the question. Anybody, any question left? Fine, ma'am. So if nobody has any other question, no questions left in the chat box.
And can I ask a question?
Oh, sure.
Yeah. Okay, so thank you for the very informative talk. And I'm basically a cytogeneticist.
Oh, great. So you would be able to answer the questions beautifully.
Yeah, I strongly believe that cytogenetics will still always be there.
Yes.
So I was just wondering, when you say atypical CML, then would you include the fish variants that you get? Like sometimes there's a deletion of part of the ABL or BCR and all those.
You don't actually. No.
Okay. No, you don't what? You don't get such variants?
We don't get such variants with having only one. So I have never seen.
Because initially when a lot was on fish and CML and all, we used to get cases with variants. So you won't get the typical signals, like, you'll get different signals that way.
So, variants also we put in CML. We've come across some variants. We've come across cryptic BCR ABLs. But then it becomes CML.
Yeah, okay.
Yeah. Not atypical. So atypical has been now renamed, no?
Yes.
Yeah. With neutropenia. Yeah.
Okay, thank you.
Two more questions have come in the chat box.
Yes.
Abdullah wants to know which method is preferable for MRD in AML with positive mutations, PCR or NGS?
PCR, I think, is better, but I know a lot of science is moving towards NGS, but we are a little premature for that. But I think eventually NGS will come. But as of now, I think PCR is the method that we are doing. But yes, I know eventually NGS is going to come.
Thank you, ma'am. Dr. Debajita Ray has raised one question. Is there any blast percentage cutoff for lymphoid blast count?
What?
Lymphoid blast in case of lymphoid blast crisis. And should we go ahead in all the cases for flow in CML where morphology blast count are less?
So I think the blast count percent remains 20%, whether it is myeloid or lymphoid, whatever it may be. And we should always do flow in blast crisis to characterize the blast crisis, because your treatment depends on it, isn't it?
Because I think she wants to know whether if the blast count is 18%, then whether to go for flow first. To say
Flow
that
for typing the blast? Flow for what?
But manually, but blast count is 18%.
Yes.
Then we should go for flow cytometry to say that whether it is more than 20% or not.
So, you know, if you look, no. So there is a difference. The count on flow is generally always lesser than you get, generally. The reason being, during the processing, a lot of blasts get lost. So I personally think you should not take the blast count on flow for a diagnosis. If your marrow is dilute, you can ask for a better marrow for count. Don't go to flow for count. Flow has so many variables that happen to it. So go for other things. It will help in typing, but don't go for counts on flow. That's my personal experience.
So manually is always best in the flow.
Yes.
Okay, thank you so much, ma'am. Dr. Rakhi Kar, your question, please.
Yes, Rakhi.
Good evening, ma'am.
Hi,
So
Rakhi.
nice to hear you.
Thanks.
Excellent talk. I just had one or two things to share from all the discussion.
Yes.
We are at a center where we don't do NGS I mean, for that matter, the high-end investigation so often, but of course we do flow. So I just wanted to add that sometimes immunohistochemistry has a role, like from the discussion, especially in acute, the pure erythroid leukemia, which is now the acute erythroid leukemia, P53 and E-cadherin, both of them are very useful. E-cadherin to delineate erythroid because it will stain only the precursors. If you do glycophorin, it will stain the mature erythroid also. Along with that P50, because P53 will not stain other erythroid hyperplasias.
Yes.
Similarly, Dr. Amit, you asked, hypoplastic MDS AML versus aplastic anemia. Simply CD34 also is very useful. Like in aplastic, you'll hardly get CD34 positive cells, but if you see in clusters, small clusters, that is useful. Even there are some mutation-specific markers which can be done by IHC.
Yes, I know. Even for NPM, you have
it has a good correlation.
IHC is coming up as a good alternative to actual mutation detection, and it can be used if you don't have
especially if there is some.
Yes, definitely IHC can be added. Definitely, that's a very good comment. Thanks.
Thank you.
Thank you, ma'am. So if anybody has any other questions, we have still time to go. Oh, yes, ma'am. Please go ahead.
So, we got not only a clinical diagnostic lab, but we are also doing a few research projects and we have an NGS in-house. So if we would like to, work on some interesting research, what would you suggest? What topic, in
So I think a lot of work can be done in MDS. And also, I think one of the topics that was raised, which mutations you could look at for MRD on NGS vis-a-vis the PCR-based or the flow-based. Each has a different connotation. We know that PCR is more sensitive than flow-based MRD, but in the guidelines, still flow-based MRD persists. So a lot of research and work is going on. What is the use of NGS mutations and all? And I think one can certainly work towards it and see the follow-up of the patients, how they do with an NGS presence of mutation vis-a-vis. We got a case which was negative by flow, and AML which was negative by flow MRD, but NPM was coming positive. And frankly, we couldn't say what is happening to it. The clinician anyway gave one more round of chemo because didn't want to take risk. But then when we searched, we couldn't find anything much on it. I think these are areas which one can always work upon. And you could do a research project on it or something.
Could you even, would you suggest, doing a retrospective study on cases where we've seen the clinical as well as the outcome to see something that we did not find previously?
I think certainly that would be good to study because you have a lot of data. If you have a lot of data, for the NGS, you could go back, because initially many of these mutations were not considered. But now in the newer scenario, a lot of these mutations are now come into cognizance. So you could look at those mutations and you have follow-ups of those patients as well. I think it could be a very good study, actually. Yeah. Actually, you could do that. Sounds good.
Yeah. Thank you so much.
Okay.
Thank you, ma'am. One question has come from Dr. Savitri Singh.
Yes.
Have you ever come across any leukemia patient with a very high ferritin of more than 50,000?
Only if the patient goes into HLH, then you'll have very high ferritin. So leukemia patients do go into HLH off and on.
Yes, absolutely.
And you get high ferritin.
Usually,
Or a lot of transfusions have been given. A lot of multi-transfusions have been given, because then again ferritin will go up. So yeah, you can get.
Absolutely, ma'am. Well, anybody has any other question? Okay, fine. So we have finished all the questions from the chat box. Thank you so much, ma'am.
Thank
there
you
was
so
one
much.
question from my
Pleasure
side.
to do this. And yeah.
My side.
Yeah.
Please, sir.
Just, I mean, final word, ma'am.
Yes.
Thank you for the update. It was very nice. My take, I'll go back to the basics.
Yes.
With all this, what is the role of morphology and cytochemistry at the current scenario?
So
You did say a few things that
together, morphology and cytochemistry. I still
yeah,
think,
ma'am, you did say things like even
there
for
is a role of
myelodysplasia.
cytochemistry. As was just highlighted, you can have MPO positivity on cytochemistry and distinct positivity, but negative on flow cytometry. So I still think there is a role of.
But you did say we don't do MPO anymore. You did say we don't do MPO anymore.
Oh,
and
okay.
for
We must do, I
myelodysplasia,
think.
Okay, we must
Even
do. Okay.
non-specific estrays, I know people say it is very non-specific and everything, but it gives you a quicker answer sometimes.
Yes,
So, I mean, I still think we should not do away with cytochemistry, but I know in my lab we have done away with it now, but I personally always believe we should still have cytochemistry as one of the ancillary tests. And morphology, still helps you. I don't think morphology can ever become redundant, because your first impression is what makes you decide, okay, isme we will do these markers. Okay, you put up a common markers for flow, initially a common tube, and then go from there. But yet I think you can't do away with morphology. Many things you pick up on morphology. For example, if you get, say, invaginations happening in the monocyte, you think, oh, let's look at CD19, let's look at some NPM or those kind of things. You do, it gives you a clue. I mean, I think you cannot do away with morphology. It gives you the first impression. If you're thinking of an APML, it's morphology that's going to tell you this maybe, not 100%. You do a FISH and it comes out as a 15, 17 positive and you confirm it. But at least a treating physician can start the ATRA to overcome any emergency. Maybe he may have to stop it later. So I think morphology is not redundant. You cannot do away with morphology. I think you should have cytochemistry if available, but it's not a very easy test actually. So a lot of labs have actually done away with it, which I think it is good to read.
Right.
If you're doing it, it is good to read it.
Thank you, ma'am.
Thank you so much, sir. And thank you so much, ma'am, for answering all our questions so patiently. You were superb and fabulous. Hats off. Thank you so much.
Thank you so much. It's been a pleasure, and thank you all for the beautiful discussion that happened.
Thank you.
Thank you, madam, for wonderful presentation.
Thank you, ma'am. Thanks a lot.
Hand over to Zydus for the final.
Thank you.
Thank you, Dr. Amit. Thank you, Dr. Renu ma'am, for excellent session, for the overview of the comprehensive. So, ma'am, and it's very important for us as well to understand the classification per se and to understand various therapeutic target, so that we can identify the various therapeutic target therapy areas that is available across world and bring it to India per se. So, so thank you. Lastly, I would also like to thank Dr. Amit Khurana sir for excellent moderation, sir, and Dr. M.B. Agrawal sir and MSG for giving us the opportunity to be a part of this session. Thank you so much, sir.
Thank you, and bye-bye. Good night, everybody.
Thank you so much.
Good night, sir.
Thank you so much, everyone.
Good night. Bye-bye.
Good night. Good night.